everyone, and welcome to Talk Nerdy. Today is Monday, July 22nd, 2024, and I'm the host of the show, Dr. Cara Santamaria. And as always, before we dive into this week's episode, I do want to thank those of you who make Talk Nerdy possible. Remember, Talk Nerdyism will always be 100% free to download as long as this show is on the air. And the way that we keep that going is by having a Patreon. It's really relying on support of individuals just like you on a per episode basis. If you're interested in pledging your support of the show, no dollar amount is too little. I feel like a telemarketer or something, like a infomercial host. All you've got to do is visit Patreon. That's patreon.com/talknerdy to learn more. This week's top patrons include Anu Bharavaj, Daniel Lang, David J.E. Smith, Mary Neva, Rika Maharaj, Brian Holden, David Compton, Gabrielle F. Jaramillo, Joe Wilkinson, Pasquale Gelati, and Ulrika Hagman. Thank you all so much. All right, let's get into it. So this week, I had the opportunity to chat with Dr. Paul Offit. He's the director of the Vaccine Education Center, an attending physician in the Division of Infectious Diseases at the Children's Hospital of Philadelphia, and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. And this man has written a lot of books. Let me tell you, I had him on the show to talk about a new book he had written called You Bet Your Life: From Blood Transfusions to Mass Vaccination, The Long and Risky History of Medical Innovation. And literally from the time we coordinated to have him on this show and we booked him and then we were able to record this interview, he wrote a whole other book and published it. So his newest book is actually called Tell Me When It's Over, an insider's guide to deciphering COVID myths and navigating our post-pandemic world. So let's learn something today. Without any further ado, here he is, Dr. Paul Offit. Paul, thank you so much for joining me today. I'm really excited to talk about your new book, You Bet Your Life: From Blood Transfusions to Mass Vaccination, The Long and Risky History of Medical Innovation.
Thank you. Thanks for having me.
So this is what, like your 10th book or something like that at this point?
I think that's exactly what it was. It was the 10th book. I have a book that has come out since then called Tell Me When It's Over, about COVID, but which was my 11th. But this was my 10th book, right?
How do you do it?
I get up early in the morning, usually around 4:30, and work for a few hours and then go into work. That's what I do.
Yeah. And so tell us what it is that you do for a living and what that job actually looks like.
Sure. So I'm a pediatric infectious disease specialist, and while trained as a pediatrician, I very early on chose to do a subspecialty training in infectious diseases, which sort of drove me into the laboratory. And then I was basically in the laboratory for 25 years, trying to understand a virus called rotavirus, which causes fever, diarrhea, and vomiting in young children, is a major cause of dehydration, kills about 2,000 children every day in the world. And me and my two collaborators, Stan Plotkin and Fred Clark, worked to create strains that became a rotavirus vaccine, which was recommended for everyone in this country and the world in 2006. And I just summarized now my entire life in about 45 seconds. It's depressing that you can do that, but I just...
Well, you've had a lot of practice probably from the press around your writings and from doing so many public interviews, because you also have had not just this, well, I don't want to call that a private role because it's not, but you've had a very public-facing role as well. Not only have you done this incredible work behind the scenes, not only have you worked directly with your patients, but you've also had a lot of connection to policy, connection to kind of public health and public science communication as well, right?
Right. So in late 1990s, up until about 2004, I was on the advisory committee for immunization practices to the CDC. And then since 2017, up till now, I've been on the so-called FDA Vaccine Advisory Committee during the COVID pandemic. So yes, I think I have been, although interestingly, I was mostly just like in a windowless concrete blocked room inoculating mice for about 20 years, but somehow that translated into a public health career.
And so you mentioned that your new book really does get into COVID, and you also mentioned that you are still in that role. And so I don't know how much you're able or how comfortable you are talking about your experience, but what what a trying position during two different administrations with or actually three different administrations with wildly different views about how to tackle this public health crisis.
Right. Well, from our standpoint, as the 12 voting members on the FDA Vaccine Advisory Committee, it was a matter of looking at the data, and there was much data to look at and a lot of pressure to do it. This book, now, You Bet Your Life, at some level, kind of prepared me for that because the point of that book is there has never in the history of humankind been a medical innovation that was not associated with some human price for knowledge. You always learn as you go. You always pay a human price for that knowledge. And it's something we never accept. People think you've gotten to a point in science where that's not going to happen anymore, but that's not true. So in December of 2020, when the committee, sat down to review initially the Pfizer vaccine and then the Moderna vaccine, we were looking at two clinical trials that involved a total really of about 35,000 people who'd gotten the vaccine, knowing the vaccine was going to be used in hundreds of millions and ultimately billions of people, knowing you were going to find out things you didn't know yet. And the only question was, how serious was the problem going to be and how common?
Yeah, I mean, I want to say I think it was just this week on the Skeptics Guide. I covered a recent article that was published about a challenge trial with COVID among unvaccinated individuals. I was unclear if they had access, but they just hadn't been vaccinated, or if the vaccines weren't available yet. But this was a study where they intentionally exposed people to COVID in the UK to see, kind of at the molecular level, how their immune system reacts to that. So it's funny because you're right. I think that we assume that we are at this place in biomedical research where there's just never any risk. And of course, there is a certain level where we wouldn't be willing to put people at risk, but there's always a calculus about acceptable risk.
Right, and you don't know the risks at some level. I mean, we would have never been able to predict, for example, myocarditis, this inflammation of the heart muscle that was associated with both mRNA vaccines. We never would have been able to have predict the clotting problem associated with Johnson and Johnson's vectored virus vaccine, which was not trivial and it involved severe clotting, including clotting in the brain, that ultimately drove that vaccine off the market in May of 2023. So, you learn as you go, and people get angry about that. They think, how can you not know this? I thought you tested this. And, you don't test something pre-licensure, or in this case, pre-approval, in millions of people. You test it in tens of thousands of people, which only reveals a certain level of risk, but doesn't tell you about rare risks.
And even as you start to see these risk profiles develop, as you mentioned with the Johnson and Johnson vaccine and the clotting issue, that was a serious enough issue that upon further reflection that vaccine was pulled off the market. But with the myocarditis issue, I think one of the biggest concerns that I often see is a difficulty understanding risk benefit relationships and understanding basically like large numbers, because there has been this narrative that is somehow riskier than protection from COVID.
Right, with sort of the sin of omission versus the sin of commission. I think people view risk as much greater if you do something and then there's a negative consequence, as compared to if you do nothing and then there's a negative consequence. I think people don't understand that doing nothing, in this case, for example, not getting a vaccine, is doing something. It's putting yourself
Exactly.
at risk of COVID. And I think people view those risks differently.
It's true. I mean, there probably is a name for it. It's got to be like a cognitive bias that we all engage in, right? That I feel somehow less responsible if it was because I didn't actually act. There wasn't a positive behavior. If I just, passively accept what would happen. But you're right, not choosing is a choice in and of itself, and that's a bitter pill to swallow for a lot of people.
Right. And I think it probably need look no farther than advocacy groups. These parent advocacy groups, for example, like Families Fighting Flu, Meningitis Angels, National Meningitis Association. These parents all tell the same story. Their child was fine. They chose not to get that vaccine, and then the child suffered and often died of a vaccine preventable disease. And their statements are always the same. I can't believe this happened to me. It's that sort of myth of invulnerability, that a choice not to get a vaccine is some level a risk-free choice, and it's not. It's a choice to take a different and as we've learned, more serious risk. But you never think it's going to happen to you till it happens to you.
Yeah. I think about a career like yours. I think about the careers of many scientists who work in biomedical research, of many practitioners who are really passionate about a science based approach to their practice. And one of the features that always comes to the surface for me, and this is my bias as a psychologist, is that there's always gray area, there's always nuance, there's always a risk benefit analysis. But when it comes to, let's say, the difference between science journalism and science communication, for example, very often science communication does sometimes come across as advocacy. And sometimes that's a very good thing. Very often, science journalism has the ethic of ensuring that the whole story is told. What you are doing as a physician scientist and writer is you are telling a complicated story that has nuance. You're talking about the risk. And in doing that, you're opening this window to oftentimes misinterpretation or weaponized intentional weaponized interpretation of risk for the benefit of somebody who has a specific agenda. Obviously, it's much easier to just say vaccines good, always the best choice under every circumstance. There was never any risk. Of course, look at the numbers, this many lives were saved. It's easy to sort of tell a story that has been cleaned up a bit. But you're actually doing a very brave thing, I think, by telling the real story. But you must get backlash for that.
Yeah, from both sides, actually.
Yeah, exactly. Talk to me about what that's been like, because the book has been out for a while now. So, a lot of people have read it.
Yeah, for me, I guess it's straightforward, which is I try and understand the science behind a statement or statements that I make, and then just try and describe it as accurately and clearly as I can, and I can live with that. Then I can live with it. It doesn't mean I'm always going to be right, but I can live with the fact that I try to do the most honest job that I could. So, for example, I'll give you a particular example with COVID. When in June of 2022. Our FDA Vaccine Advisory Committee sat down to decide what vaccine to use that coming year. That in a few months, it's about a 3-month production cycle for these vaccines. Omicron had entered the United States. This was a much more immune evasive strain. It had entered in December of 2021. Up to that point, we'd only been given the original strain, the so-called ancestral strain. The Wuhan 1 strain. But now we decided, look, we need to go to one of the Omicron variants. So we sat around and we said, okay, let's give a half a dose of the Omicron and one of the Omicron variants, and we used sort of BA4, BA5, and then a half a dose of the ancestral strain. That wasn't a bad idea, but it didn't end up working out well. Because if you looked at just the immunological data initially, it was completely not compelling. So I was a no vote. I was one of 2 no votes. I didn't think this was any better than what we had. And I got a lot of pushback for that. Then what happened was the immunological studies were done showing that it really wasn't any better. It wasn't worse, but it wasn't better. Then the clinical studies were done, meaning were you less likely to get disease if you'd gotten this bivalent vaccine than the original sort of monovalent vaccine that just contained the 1 strain. And so I wrote an op-ed in the New England Journal of Medicine, and I was occasionally, because I was on TV a fair amount, asked on television to talk about that. And I think that the moment that crystallized it for me and crystallized in some level the pushback I got from the pro-vaccine people was I was on CNN with Pamela Brown. And she showed a sort of 2-minute clip with Ashish Jha, who was the head of the COVID response team at the White House. And he's saying, look, got to get this vaccine. The bivalent vaccine better. It contains the Omicron variants in it. It's much more up to date than the other vaccine. This is a better vaccine. And so then, now I'd already written the New England Journal of Medicine piece. Pamela Brown turns to me and she says, is he right? And, this is not something my hospital would in any sense enjoy. It's me in any sense going up against, the COVID response coordinator for the White House. So all I said was, it doesn't matter what he says any more than it matters what I say. The only thing that matters is what the data show. And here's 2 papers that were just published in the New England Journal of Medicine that showed it was no better. It was no worse, but it was no better. And I think because we were so desperate to get people vaccinated because we sort of very quickly got 70% of the country vaccinated, but 30% simply refused to be vaccinated. So I think we erred on, and this is your point from earlier, we tended to err on the side of overselling it. But when I said, look, I don't think this is any better than what we had, I got a lot of pushback from public health people that I was now off the bus. I mean, these were the few remaining people that seemed to like me in this world, and somehow managed to alienate them.
Well, because you weren't saying don't get vaccinated. You were saying you can get this vaccine, you can get the other vaccine. Just be vaccinated.
Yeah, but those who were opposed to vaccines, or certainly opposed to vaccine mandates, said, look, see, here's a scientist saying it's not any better, and here they're telling us we got to get it because it's better. So I was used as sort of the poster boy. I mean, I was getting like, love letters from anti-vaccine activists, things like, I have been praying for you and your family for 20 years, and now finally my prayers have been answered. I was asked to appear on Newsmax. That's when you know you're not getting the
Wow.
message out there.
And that's, I mean, what a difficult situation where I see this a lot when it comes to scientific or science communication. Obviously, scientists and science communicators are not saints. They are not perfect. Very often, though, I do think that they are doing work that is fundamentally ethical. The idea here is to educate the public about something so that they can make informed choices that will hopefully benefit public health as a whole. And when we're seeing groups that are intentionally, whether it's misguided or whether it's nefarious, intentionally undermining public health efforts, they're not playing by the same rules. And I think sometimes that's the frustration, right? Is like, okay, well, I refuse to hit below the belt, but you're hitting below the belt all the time and you're getting results for it.
Right. It's sort of like guerrilla warfare. I mean, you're like the British troops marching in a straight line. You have people picking you off in the trees, and because they don't follow any rules, they'll just lie and lie and lie, and that's why it's so impossible to, in any sense, engage them. I mean, I've been asked several times by people supposedly representing Robert F. Kennedy Jr. Look, we'll give you $50,000 to debate RFK Jr. That's not a debate. I mean, you might as well debate whether birds are real. All you would do is say, look, that's not true, or that's not true. And so how does that, in any sense, advance people's understanding of the issues?
Yeah, it's such a tough position to be in. And so, why don't you kind of like let us know, I guess, a little more about how you choose to approach these topics? What goes into your thinking when you decide to write a book that, and maybe it's not a safe assumption, but my assumption is that you're hoping will get into the hands of individuals who do want to be more educated on these issues and understand the nuance a little bit better.
Right. Well, the motivation is always the same, which is, advocacy for children's health. I mean, I'm, a pediatrician for a reason. I mean, I think I was always drawn to sort of seeing children as kind of vulnerable at some level and to trying to protect them. And so part of that is trying to explain in many different ways what not only what risks and benefits are, but sort of how science works. I mean, what you can reasonably expect from science. And how it is a process in evolution always, and how you have to be open-minded to that process. And a book like Pandora's Lab that I wrote, sort of 7 stories of science gone wrong. So it shows sort of 7 examples of science that did a lot of harm, like sort of in the range of something like, eugenics, for example, was a science of kind of forced sterilization, which was based on, scientific treatises that were just wrong. And to sort of show our vulnerabilities as a way of trying to explain, so people can understand all this better, because it is hard. I think, when for example, the problem with clotting occurred with the J&J's, Johnson & Johnson's vectored virus vaccine, people were really angry. And it was a complete surprise that this adenovirus vectored vaccine would cause clotting. And it caused us to understand not only could that vectored virus do it, but natural adenovirus infection could do that, which nobody realized before that. So you looked a little closer, and you learn as you go. And that's just something that we're never able to accept.
Yeah, yeah. I mean, it's such a difficult thing in a political climate that has, I don't know, in some ways, I guess, been maybe not founded on, but this ethic has been reinforced, in which you don't double down, you don't waffle, because if you do, then you're non-committal, and you really have to stick with whatever decision that you make, and that decision needs to, that's how I know that you're a strong leader. That is in direct opposition to the fundamental ethic of science, but also I think a very humanistic ethic, which is like, I don't know, should we be learning all the time and growing and improving and getting better and being able to say, that was a mistake we didn't see coming. Once we recognized it, we attempted to fix it, and we made decisions that would be in the best interest of public health. I often worry that human hubris, even within medical establishments, and definitely those that are aligned with government or that are kind of run by government, that human hubris can get in the way, where people go, I don't want to admit that we made a mistake. That's going to be disastrous for our public image. Let's just pretend we didn't.
Yeah, and I'm not sure it's just hubris. So, for example, when we made a bivalent vaccine, you'll notice we haven't made a bivalent vaccine since. So we haven't, because the 2.5 dose idea was a bad idea. It wasn't a bad idea. It just wasn't any better than what we had. Should we have done that? Should we have stepped up and said, look, we've learned from this. You'll notice that there aren't any more bivalent vaccines. We're just using a monovalent vaccine at a full dose instead of 2.5 doses, because we learned. But I think the fear is that when you do that, when you say, look, we got this wrong, there will be a segment of the population will say, see, you just can't trust these people. They just get it wrong. And so people sort of don't say that. I remember I called a lot of people when the bivalent vaccine data were first presented to us, the immunological data, and then there were more immunological data out of Dan Baruch's lab at Harvard or David Ho's lab in Columbia. It was clear this wasn't going to be much better. And then the clinical data came out in the New England Journal of Medicine paper, and it was that was very clear that this was. So I called all of them. I called Dr. Fauci and I called Dr. Walensky at the CDC and others who were, and Dr. Jha, who were representing this, just to say, we should be careful here about how we're describing this, because I think we're at some level could be perceived as misleading people when we're all see, there's nothing nefarious to me about what people were saying. They were trying to do the right thing. They wanted people to be vaccinated. And certainly this was no worse than what we had. We were just at some level misrepresenting it as being better. And it was really stressful for me, all of that, because I really like these people. I think we're all trying to do the right thing. And you're caught up at a time when hospitals were, still largely overwhelmed. You were seeing thousands of people die a day. You wanted people to be vaccinated. And it was just a very stressful time.
Yeah, I mean, I think you see it a lot, that sometimes decisions have to be made where the rhetoric or the recommendation is firm and clear and lacks nuance, because the more nuance we put into it, which is more reflective of reality, it also is more confusing, and it increases it might increase distrust, or at least an inability to weigh the options in an educated way. And I think that's often the problem with science communication and public policy communication around medical issues, is that some of them are quite simple, but some of them are exceedingly complicated.
Yeah,
Exceedingly complicated.
I completely agree. There's one other aspect that's sort of interesting to me, and certainly in the writing of the book, You Bet Your Life, it came up, especially in the area of vaccines. When you do prospective placebo-controlled trials, as we did in the sort of 3-month period between pretty much October and December, when we had those mRNA vaccines, those are placebo-controlled trials. I mean, those are people who randomly will either get a vaccine or not get a vaccine. And there was a death in a person in the placebo group, because they just, by the flip of a coin, didn't get, the vaccine. I remember I have a friend, I'm in North Carolina, who he's entered into this placebo-controlled trial. So he doesn't know what he's getting. But then the next day or the day after getting his shot, he wakes up, he has fever, he has, pain in his arm, he's got swelling of the lymph node under the arm. And he said, yes, I got the vaccine.
Yeah.
And I think that the example I use in the book, which I think is the most horrific example, and it just says, and I actually wrote a separate book about this called The Cutter Incident, but it was the polio vaccine trial. You have Jonas Salk, and Jonas Salk didn't want to do this trial. He had done studies in Pittsburgh, in and around Pittsburgh. He had inoculated 700 people with his vaccine, his whole inactivated polio vaccine. He thought you induced an immune response that protected kids, and he didn't want to do a placebo-controlled trial because here in the mid 1950s, when that trial was being done, as many as 25 to 30,000 children every year were paralyzed by that virus. 1,500 children were killed by that virus. He could not conscience giving a placebo to children then. So the trial was done. 400,000 children got the vaccine. 200,000 got a placebo. And the vaccine was found to be very safe and very effective. But how did you know it was effective? You know it was effective because 16 children died from polio in that study, all in the placebo group. 36 children were paralyzed in that study, 34 in the placebo group. I mean, these are the gentle heroes we left behind. But for the flip of the coin, those children could have lived long and productive lives. And that's the sort of casual cruelty at some level of these placebo-controlled trials.
Yeah, it's an interesting ethical conundrum, right? That there's almost like a before we know and an after we know. And obviously, after we know, it's not ethical not to treat. Before we know, there is no treatment. But during us knowing, that process of discovery, the process of knowing, there are going to be people who are almost like the before people, and there are going to be people who are like the after people. And like you said, it's a coin flip.
Right. That's
It's
right.
such it's such a tough calculus, and I think in some ways it's not the reason we do double blind, studies. We do those so that there's no influence, but even unconscious bias. But in some ways, I can imagine that must protect the researchers' psychology as well. Because gosh, like being involved in that must be really psychologically trying.
I would think so, especially when you look, for example, at the original data with the mRNA vaccines. You knew, and this is, I'm at Penn, so Drew Weissman and Katie Carrico, who won the Nobel Prize for that work. I mean, they had excellent, experimental data. They had early human trial data. They knew that vaccine induced an excellent immune response against SARS-CoV-2 by using this mRNA against the surface protein or spike protein, fusion protein. And then they stand back and then watch Pfizer or Moderna do those trials. I'm sure they knew that were they part of those trials, they would love to be in the vaccine group.
Yeah. Yeah. Oh gosh, yeah. And it's interesting. We've been talking a lot about vaccination, which is, an important component here. It's a big part of your work. It's a big part of what you talk about in the book. But one of the examples, I guess you could say, that is very kind of relevant to me. So I'm a psychologist who works in a cancer center, and very often the work that I'm doing with patients is navigating that risk benefit analysis, especially those who are stage 4, especially those who are trying to decide, do I want to go back to my first line therapy, or am I willing to go into this clinical trial, or at what point do I say the risk isn't worth, the quality, like I don't have quality of life at this point. So those kinds of calculations are always really fascinating to me, and they also occurred during the development of these drugs. But even when we know a chemotherapy is, effective, you're taking on a massive risk when you take a particular treatment that, one of the side effects could be a cytokine storm, or it could be another form of cancer developing. I think cancer patients specifically have a deep understanding of risk benefit relationships because they are confronted with them all the time.
Right. And there's such a difference between treating somebody who has a disorder as compared to prevention, because with prevention,
Right.
you're giving it to healthy people. But I do think people don't understand risk. It's very hard to get them to understand it numerically. I mean, whether you say 1 in 100, 1 in 1,000, 1 in 1,000,000, they hear one. And I think
Yeah.
the New York State Lottery. I'm not sure they still do this, but when they were selling lottery tickets, they at one point it was like a 14 million to one shot, roughly, if you're winning. And they sold a lot of lottery tickets with the simple phrase, "It could happen to you."
Yeah. Someone's got to be that one, right? Jeez. Yeah, and I mean, this conversation about risk, I think, is a really, really important one. That even something like, let's say, a life-saving chemotherapy. Let's say that an individual is early. They caught their cancer early. They're stage 1 or stage 2. It's not it hasn't metastasized, especially not all over the body. And there is a potential for a curative intervention as opposed to just a treatment, something that kind of gives more time and sort of whack-a-moles the cancer and keeps it at bay. Even still, engaging in these medical decisions are risky because chemotherapy is not innocuous. It's the best we have. And some of them work really well and have very minimal side effects. Some of them, you feel like you're dying on these drugs. And others, like we mentioned, can cause secondary medical problems that you didn't have before you sought treatment. What a position to be in as a patient. How do you work with your patients who are navigating, trying to make those very difficult decisions?
And I think, we always talk about, phrases like shared clinical decision making, that the patient is also going to be part of this decision. But you, as a patient, you don't really know. You're really trusting your doctor to sort of lead you as to which way to go because you don't know. I mean, I was with the Advisory Committee for Immunization Practices now has occasionally uses phrases like shared clinical decision making. And I think that's at some level unfair to the clinician, and just make a recommendation or you think it should be used or not, and then have the physician explain it. But I think
Yeah, I
when they
see
sort
both
of show
sides
up,
of that with
yeah.
patients a lot. Like I see the attempt to be as sort of open as possible, and you have patients who are sitting across from a physician saying, "Well, we could do this, we could do this, we could do that, we could do this. What do you want to do?" And they're like, "I don't know. I don't have any expertise in this." And then you see the opposite, which, I remember a terrible situation being in a hospital with a patient who was clearly end of life, and their oncologist was pushing for more radiation treatments, and those radiation treatments were incredibly painful. And I remember that, looking at the patient as her psychologist and saying, "Do you want to keep doing this?" And her saying, looking to the oncologist and saying, "Is it helping?" And he hemming and hawing, "Well, I mean, there's, this and that. Okay, then I guess I'm going to do it." And it's I think you often see both sides of that coin, too much choice. I don't want to say too much choice, but too much uninformed choice can be just as uh, difficult as, I'd say, a physician who hasn't done the emotional labor to cope with their own fear of death, who keeps pushing treatments long after probably they would be all that beneficial.
Right. And even more recently for example, prostate screening programs and, thyroid scans to prevent thyroid cancer. I mean, there's sort of a growing body of evidence that it's not really clear whether you're saving someone's life, and you put them through a lot in the process of trying to prevent cancer. And I think we just need to get better at this because we're not quite there yet on some of these screening programs.
I'm curious what you think then about these growing trends that I'm seeing in like social media where young, healthy people are visiting centers, very often in other countries, but sometimes here in the United States, are getting these like full body scans or these really intensive screening protocols. They're paying out of pocket for them to look at like everything they possibly can. I feel like there's got to be a massive risk there.
Yes, it puts way too much faith in modern medicine. I mean, they'll find something, and if they find something, the question is then does finding it really help you? Is the question. So I would, I definitely would. My general attitude is avoid doctors, but yeah, I can see where sometimes you need to see them.
Tell me more about that. What do you mean when you say avoid doctors?
I went to a physician recently and just got 1,000 tests. And, so you have prediabetes, you have this. I mean, we need to check on this and this and this and this. And I'm thinking, really? First of all, I'm like in my early 70s. Can't we just let me sort of coast to my end in some level of peace here? It's more than I wanted to do, because you sort of enter this system and then you're just getting all these tests. And you really wonder to what extent. I wrote a book about this called Overkill When Modern Medicine Goes Too Far, about how at some levels, a lot of these screening tests don't give you, don't prolong your life and just sort of make you miserable. Also, I prefer not to know some things, surprise
Yeah.
me.
I always ask my patients that as well, because for some people, I think the anxiety that comes with their medical experiences can be quelled by more information, and for other people, it is exacerbated by more information. And it's deeply important to understand an individual's stance when they're going into treating, a life limiting illness, because if we just assume that everybody's psychology is the same, that is a recipe for disaster. It's a recipe for, I think, really poor mental health throughout this process. And, something else comes up for me. I often, I do a lot of work in sort of end of life and medical aid in dying. And, that's what I wrote my dissertation on. And often the kind of rhetoric or the pithy thing that we say around that is like, we treat our pets better than we treat grandma when it comes to like choice and death. But I often think we treat our pets better than we treat people in terms of how we run tests, because we are faced with a decision when our pets get sick that is like, do I pay for that additional screen? Do I do the scan? This just happened to me. My pet had a stroke. My dog had what we think was a cerebellar stroke that resulted in a vestibular kind of syndrome. And I asked, should we get a scan, an MRI? And they were like, you're going to have sticker shock. I need to warn you. This is going to cost between $6,000 and $8,000. And I was like, oh my God. So what will I know if we do this? And they were like, we'll know if it was a stroke or a tumor, but we'll also know that if we just watch how he recovers. And ultimately, it won't change the way we treat. And I felt like, thank you for being honest with me about that.
Right. That's interesting.
Because that doesn't often happen, right? And I think there is kind of a weird ethical thing there where that do no harm sensibility is taken to its extreme, and that for a very long time, the ethic of medicine was, unless we throw everything at the problem, we could have missed something.
That's right. I think that's right. The notion that we can prevent anything, but there's always a cost to prevention, and getting people to understand that, or getting doctors to understand it, has been a challenge. You're right.
And how do you navigate that role? Because not only are you a doctor, but you are an educator of doctors. You're an educator of the public, but you're also an educator of doctors. Do you feel like you've been able to make a difference? Do you feel like that's maybe just not a role that you want to take on?
No, I think I have, to some extent. I mean, I've been fortunate enough to be given, maybe through the writings of these books, somewhat of a platform, or being on these advisory committees, getting somewhat of a platform. Yeah, I think so. I think, we created the Vaccine Education Center at Children's Hospital of Philadelphia, to get people to try and understand what vaccines can and can't do. I mean, I'll give you another example, just since we're in the COVID world, is when the vaccine was introduced in December of 2020, the studies that were done by Pfizer and Moderna showed that the vaccine was like 90% effective to 95% effective, not just against severe disease, but all disease, even mild disease. There's no way that was going to last. I mean, protection against mild disease is mediated by antibodies in the circulation. Antibodies in the circulation are generally short-lived, usually gone 4 to 6 months later. So when 6 months later studies were done showing that you still had greater than 90% protection against severe disease, you were down to like 50% protection against mild disease 6 months later, which is exactly what you would have expected. And we did a terrible job of explaining that. So, for example, there was an outbreak in Provincetown, Massachusetts. Thousands of men get together. They celebrate the July 4th holiday. In Provincetown, about 80% were vaccinated. Nonetheless, there's a COVID outbreak. And 346 men who were vaccinated got COVID. 4 were hospitalized. So a hospitalization rate of like 1.2%, which is great. That's a vaccine working well. The remaining 342 had either mild or asymptomatic infection. And when the CDC reported that in their journal called Morbidity and Mortality Weekly Report, they described those as breakthrough infections. Yeah. Bad word. Breakthrough implies failure. That wasn't a failure. That was a moment to celebrate. The vaccine was doing exactly what it was supposed to do, keeping you out of the hospital. I mean, I remember I was on CNN for something, and because you sort of wait for about 10 minutes or so before you go on, so you're seeing the segments before you. And they had a thing with Brett Kavanaugh, right, Supreme Court justice, just as part of going into the Supreme Court chambers. He was tested. He was found to be positive. So he had an asymptomatic infection. And the way he had a quote unquote breakthrough infection. And the way the media carried that, you would have thought the man was fighting for his life. He had an asymptomatic infection. Lindsey Graham, for example, had a sort of 2-day mild illness. He had been vaccinated, and he said correctly, he said, this would have been much worse if I hadn't been vaccinated. Right. Lindsey Graham got it right.
Yeah, I'm so glad I did not catch COVID until I think it was 2023. Yeah, until last year, because I was real vaccinated at that point. And that made me, and I know that the reason that my experience was only 4 or 5 days, felt like a mild cold, was because of all of that immunity that I had, that I was lucky enough to gain leading up to it. And I wonder if it's a goalpost issue. I'm curious how you think about this. When we set the standard to be perfection, 100%, protection, then, we see that some people still get sick. We call those breakthrough infections. It's implying that it should have been perfect. Whereas if we set the standard to improved immunity, like you have a better chance. Your immune system is going to be better prepared now when you are exposed to this, virus. Then it's like we're noticing the wins, not just the losses.
Yeah, and I think what it really boils down to, at least in the world of infections and viruses, is the incubation period, meaning the time from exposure to the virus to developing symptoms. So for short incubation period diseases, like COVID or influenza or respiratory syncytial virus, those viruses, rotavirus, you need antibodies to protect you against mild disease. And because these are short incubation period infections, that you have to have antibodies really present at the time of exposure. And so that antibodies fade. So you're not going to get long-lived protection against mild disease. For long incubation period diseases like measles, for example, you don't need to have antibodies present at the time that you're exposed. You just need immunological memory because they're long incubation period diseases. So there's plenty of time for those memory cells to become activated and become effector cells, like antibody secreting cells or T cells that then, kill virus infected cells. That's all you need is immunological memory. So you can eliminate those diseases. You can eliminate long incubation period diseases like smallpox or measles or polio. You can do
or
that.
even hopefully soon HIV.
For sure. Yeah, that's right.
Yeah, I
Another
think we're
long
getting
incubation period disease, right.
super close with these PrEP drugs. I mean, it's incredible. But you're right. Like uh, uh, I don't know. Is it a misunderstanding? Is it a lack of education? Is it, this is the age old argument, I think, with public science and health communication is like, yes, we're always talking about educate, 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 but oftentimes it's not a knowledge deficit problem, is it? It's a misunderstanding or it's a misinformation problem, and it's much harder to knock a receptor. I always think of it in terms of receptor binding. Like it's much harder to knock something that's already bound out and replace it with new information than it is to fill a gap in somebody's knowledge.
Right. I think that's the old Mark, or at least a line that's attributed to Mark Twain. It's not what you don't know. It's what you know for sure that just isn't so.
Right. And so, kind of communicating those things can be really tough. I have an actual, I don't know if it's a technical question, but I'm curious because you have so much expertise. I was always under the impression, so when it comes to the flu vaccine, right? I get my flu vaccine every year. I would anyway, but I work in a hospital, so I'm also required to. I know that it protects me to some extent every year against the flu, and that the effectiveness varies based on a lot of different factors. Now, I was under the impression, and you sort of pointed to this earlier with regards to the COVID vaccine, that because I get a new shot every season, even if it's not a particularly effective vaccine year, I'm still kind of accumulating immunity. Is that true?
So flu is tricky in the sense
It's weird, right?
there's this imprinting phenomenon. So when
Mhm.
the virus you're first exposed to, usually a natural infection when you're little, kind of biases you toward that being protected against that particular virus. So with the immunizations that you get subsequent to that, you tend to respond at some level as if you were still responding to that first strain. So that's the hard part about flu. The one thing about flu that's good is it's really a winter disease. So you know that to get the vaccine, September, October, November should protect you fairly well through the winter, which is what is different for COVID. Because although everybody assumed that COVID at some point would settle into being a winter respiratory virus, that hasn't happened yet. It still can occur throughout the year. And because protection against mild disease will only last 4 to 6 months, there are some people who reasonably say, look, I'm in a high risk group. I'm going to get 2 vaccines a year and try and keep my immunity up for that whole 12 months, which does actually make some sense.
Oh, that's interesting. Yeah. So maybe some individuals who are like older adults or individuals who have, immune difficulties or whatever, all the different high risk groups, that might be in the future a recommendation. So we're still trying to figure out what the what this is going to look like moving forward, or do we have a pretty good idea of what life with COVID is going to be like? Like this is going to be with us now for ever, right?
Yes, I think
Okay.
you should never make a prediction about this virus because you're always going to be wrong. But I think, if you look at, there are 4 strains of human coronaviruses that circulate, all of which, like this one, had its origin in animals, specifically bats, and then through an intermediate host. One of those strains entered the human population in the late 1700s. Another one entered the human population in the late 1800s, and they both still circulate. So I think it's fair to say, actually, President Biden said this. He said, I think that the pandemic's over, but the virus isn't. That's true.
Mm-hmm. And it's almost like the difference, I think, between drought and famine, right? Like the pandemic and the presence of the virus, like we now have these incredible treatments and these incredible defenses. And so even though the virus still exists, we are not as sensitive or susceptible to it. I think about that with drought and famine, right? The drought is the natural thing that is going to happen, but famine is kind of human made. Like we have preventive mechanisms to ensure that we take care of people.
Right. So what's interesting is first of all, you have a very high level of population immunity now. It's the rare person who has not been either vaccinated or naturally infected or both. So although this virus continues to evolve, meaning that you're always having these sort of new strains that are being created, you're still, for the most part, recognizing conserved regions on the virus. Because you look last year, I think immunization rates for that yearly vaccine was about 20% or so. So most of the population isn't getting a yearly vaccine. The virus continues to evolve, yet you're still generally protected against severe disease because it's what we never talk about, but there are conserved regions on this virus where, meaning epitopes or immunologically distinct regions on the virus that are true for all the strains ever since the first strain, that hasn't changed. And that's where T cells come in. And we never talk about T cells, but T cells are important in protection. So I think that's why you see, hospitalization rates are still very low. So are death rates. So it's settled into flu, meaning every year I think we can expect hundreds of thousands of hospitalizations and tens of thousands of deaths, just like you see with flu every year.
It's funny because at the beginning, right, there was this, I think, in an attempt to not cause panic, this comparison to flu early on as a messaging tactic. And then there was a massive movement away from that. Like, wait, this is not the flu. This is way more dangerous. This is killing a lot of people and it's causing all of these secondary problems. And now it's interesting that we've sort of been able to, through all of these, mass vaccination programs and stuff, settle back into that kind of an understanding.
That's right. I think that's right because it wasn't flu initially. I mean, when people hear the word flu, they think, well, just the flu. That's always part of the phrase, right? It's just the flu. But flu can certainly kill you. I mean, I'll give you another example just because I was in a Naples, Florida airport heading back to Philadelphia. And so I'm sitting there waiting and an airport worker who clearly was ill. He had congestion and cough. His nose was running profusely. He kept wiping his nose on his sleeve. And I'm watching as he's walking up and down the aisle, sort of sweeping. And I'm looking, because this is Naples, Florida. There were a lot of older people there. I'm watching with the looks of progressive horror as he got closer and closer to people. And one woman actually had the bravery to say, did you test yourself? And he happily said, yes, right? Like I did. Now, I wasn't wearing a mask or anything. So it's like, no, yes, I don't have COVID. I'm just going to kill you with one of these other viruses, flu or RSV, right?
Oh, it's so true. It always makes me crazy when people say, yeah, just a flu, because I think two things are going on there. I think one, it's like maybe they've been lucky enough that every time that they have contracted flu, they got over it and it didn't kill them because of all of the incredible, approaches to medicine that we have now. But two, I think a lot of times people call colds the flu. Like they say, oh, it's just a flu. And I'm like, do you remember how horrible you feel when you actually have influenza? It's a brutal disease.
No, I remember when I was in medical school, one of the older physicians said every medical student should get an influenza infection so they can know what it feels like to really be sick.
Yeah, it's like you're oh my I think back to all the times in my life that I've been sick from different things, and I think influenza and norovirus have been the two that like dramatically affected me the most. Influenza, I felt the sickest in my bones, and norovirus, I felt the sickest in my gut than I have ever felt. And I think sometimes we have this like very human way that we just sort of we're good at forgetting the pain. Maybe that's what helps us keep moving forward in life. But yeah, I never want to experience that again. Thank goodness for my flu shot every year. And to be fair, I know some people have gotten the flu with a flu shot, but since I started getting flu shots, I have never had the flu.
Well, meaning that they still get vaccinated, still get influenza, sure, but the flu vaccine is inactivated, so you don't really
Oh
ever
yeah,
get
no, I don't
flu.
mean from the flu shot. I mean people who get the flu vaccine every year might still
Right.
catch influenza in the community.
For sure.
Yes,
Yeah,
I know that happens because the effectiveness isn't
it's not
100%.
great. No,
It's not great,
it's
yeah.
more like
But
60.
I'm very lucky. I've never gotten the flu since I started getting flu shots.
Wow, that's
Yeah, I know. Yeah, I'm like, thank goodness, because the flu is horrible. So I want to just ask as we're finishing up here, not just this book, but also your newest book. Is there anything? I mean, there's a million things that we didn't talk about, but is there anything that you feel like if we don't touch on it, it would be a disservice? Like, is there anything that you want to make sure that we discuss before we close out the interview?
I think that what worries me actually is that we've kind of evolved to science losing its place as a source of truth. It's just sort of like another voice in the room, that expertise doesn't matter. And there's probably no better example of that than the so-called lab leak theory. I mean, it's really important to understand the origin of this virus, SARS-CoV-2, because we had a SARS-1 outbreak in 2002. We had a MERS outbreak, another pandemic coronavirus in 2012. Now you have this virus in 2019. That's 3 pandemic coronaviruses in 20 years. Assume there'll be another one. So it's really important to understand the origin. And if you look at the scientific data, it's clearly an animal to human spillover event that occurred in the southwestern section of the Hunan wholesale seafood market at the end of 2019. All the early cases were there. The virus was identified there. There was DNA, mammalian DNA from animals that definitely were susceptible to the virus that were there. That's not a scientific controversy. Yet 2/3 of the American public, independent of your political affiliations, believe that it was a lab leak because there are people who stand up, people who, like Luc Montagnier, who's a former Nobel Prize winner, or Robert Redfield, who was a former CDC director, and say this was a lab leak. And it's just really upsetting to me that we are influenced in that way, and that scientists haven't been great at making it clear. And maybe it's just because people get their information from social media. Conspiracy is much more interesting than just going through scientific facts, but you're kind of watching this science losing its place, and it's something we will suffer from.
It's tough. I agree, and I think that one of the things that I always try to caution myself to do when I'm working in this public science communication arena is it can be very easy to blame the recipients of the information who don't have the academic background to always differentiate and to say, oh, these people, they're very susceptible to this, or they just want it to be that. But I think what we don't often do is talk enough about the perpetrators, the individuals who are spreading the rhetoric, oftentimes for a very explicit agenda. Not always. Sometimes I think there is this chain reaction of just people, this speaks to their vulnerabilities. And so then they continue to, we see this a lot with I don't want to open up that can of worms, but the autism, the false vaccine autism connection that was, spread. We saw Wakefield. This was intentional. This was a choice that was made, and it was a very intentional, agenda-driven choice. But then you saw other people who spoke out who were desperate, and that's why they were continuing the rhetoric. And it's a difficult thing because it happens all the same, but we put so much onus on the individual, and we don't. Or sorry, on the end user, right? The individual who is being oftentimes fed this rhetoric. And I don't know if we're spending enough time really putting the feet to the fire of these perpetrators of this kind of, this violent public health, these lies that are being spread.
No, you're right. I mean, if you use the Wakefield example, so he postulated incorrectly that the measles, mumps, rubella vaccine caused autism. So there's been 18 studies in 7 countries on 3 continents showing that wasn't true, and yet he still puts that out there, and he still has a
Yeah.
following. But
Yeah, he makes the
because,
documentaries, and
but see,
it's his
it
thing
doesn't.
now.
In a better world, it shouldn't matter what he says, or it shouldn't matter what I say. The only thing that matters is what the data show, and the data are clear. But data don't speak for themselves. Somebody always speaks for them, and that's where we get in trouble. Because if you have a charismatic, attractive, well-spoken person who's giving you bad information, that may be much more influential than someone who is little more droll, more likely to resort to jargon when he or she tries to express information. So we're always at risk at some level.
Yeah, case in point, the most recent presidential debate. You're so right. There's always going to be this difficult thing where, when one individual doesn't necessarily play by the rules, when one individual can just say whatever they want to say, and then when the scientific community says, "Well, we got to tell you the risks and the benefits, and we got to show you the nuance here," it's pretty hard to, as an uninformed consumer, to go with the thing that feels less sure, and it's a difficult problem to solve.
You're right. I agree.
And so hopefully this book will help some individuals who are struggling with that continue to increase their knowledge about it, continue to work towards that solution. So, Dr. Offit, I want to thank you so much for spending time with us today, sharing your insights and engaging with us on this incredibly important topic, and of course dedicating so much of your career to spreading that insight as well.
Thank you. It was my pleasure. I enjoyed it.
And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.